3 keys to IT band pain treatment. What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists. We work at Champion PT and Performance. Like always, we go through the literature. We take out all of the good information, throw the rest right in the trash can. We do the work so you don't have to. We also practice on a regular basis, making mistakes, hurting our patients, sometimes helping them too. So here we are. How you doing today, Kevin?
I'm doing well. We have a little bit of rain this morning, but this might be good for the lawn that you just had aerated, right?
Oh, yes. I am very excited about my lawn. I'm not going to go in depth, but this is really nice having the rain. It's been good.
Yeah, it's been nice weather, so it's all right to have this every now and then.
Yeah. I'm quite excited about ITB pain treatment this week because last week we did the evaluation in the background. I had a patient. I nailed the diagnosis, but I had to send him home. So I didn't know how to treat him. This week, we're going to learn from Kevin Coughlin how to best treat these patients, and then I'll call my patient back up.
All right, so just getting into a little bit of background about IT band pain. It's the most common source of lateral knee pain, and we'll talk a little bit about differential diagnoses. But if you have someone coming in, especially a runner with lateral knee pain, a flag should go up where you're thinking about IT band pain. It is common in runners, so it makes up 5 to 14% of all running related injuries. I was looking this morning. I can't remember the source, but it's in the top 5. So you think like patellofemoral pain, Achilles tendon pain, shin splints, and then this is somewhere in that top grouping. Pain is usually reproduced when the IT band is tensioned. So we'll talk about the anatomy in a little bit, but when the knee is flexed to about 25 to 35 degrees of knee flexion, with the hip kind of in neutral or a little bit extended, is when you really get a lot of tension through the IT band. And then the pain is usually localized to the lateral knee, although it's not always on one pinpoint spot. It can be a little bit diffuse. But there's a structure on the tibia called Gerdy's tubercle, and that's where the IT band attaches, and you might get some pain in that location. But it's not generally like a mid thigh pain. It's more distal by the knee. And as time has progressed, it's believed to be more of a compression based injury rather than a friction based injury, which is definitely something I heard a lot growing up. But I think as we learn more about the anatomy and learn more about IT band pain, we're learning it's a little bit more of a compression based injury.
Mm-hmm. Yeah. When I graduated PT school, I thought I'd see a lot more folks with ITB pain. And I literally saw, I would say none. I would say in the first couple of years, I don't even remember seeing any ITB pain, excuse me. But then again, if you work with a lot of runners, you see it a little bit more frequently. So it seems to be pretty common there. The other piece too is if you want more information on the background, go check out the link in the show notes for the last episode. We went pretty far in depth on that. Pardon the interruption, but I've got something I really think that you're going to love. It's an evidence-based guide to IT band pain. And you know it stinks. You have a patient that comes in, they have a pathology you haven't seen in a while, IT band pain, right? Pops up every once in a while. You don't remember how to treat it well. What does the evidence say? I don't remember. Well, now you don't have to fake it because my promise to you is I'm going to catch you up to date on IT band pain in under 10 minutes. The evidence-based cheat sheet is a 5-page PDF, and we go over all things IT band pain related. Background, population, biomechanics, anatomy, a mechanism of injury, diagnosis, differential diagnosis, treatments, and then natural history. Does this thing get better over the course of time? Does it revert to the mean? Well, you got to download it to find out. Best thing is that it's 100% free. So go ahead and click that link in the description, in the show notes. Download the cheat sheet and catch yourself up to date on IT band pain. Back to your video.
So just going over the anatomy. The IT band is kind of a giant tendon. You could think of it as a giant tendon that's a combination of your tensor fasciae lata muscle and your glute max. So those two muscles kind of combine into this big tendon, the IT band. So it does cross both the hip and the knee joints. The TFL itself is responsible for hip flexion, hip abduction, and internal rotation. And the glute max is responsible for hip extension, hip abduction, and external rotation. So a lot of different movements around the hip and the knee are going to cause the IT band to be active. In terms of biomechanics, I think you might have said this in our first podcast that humans are the only animal with an IT band. It's
Hmm.
pretty interesting.
Hmm.
It's believed to function as a strut during upright walking, and it acts as both a hip and knee stabilizer. Primarily stabilizes in the frontal plane. It does a good job of resisting varus loads to the knee. It also, where it functions as a tendon, is it utilizes a lot of energy storage and release during running. So it stores and releases up to 5% of the total positive work at a moderate paced run. And just to compare that to the Achilles tendon, which is kind of the power tendon with running, that stores up to 40% of energy. So, not that much, but, when someone's a distance runner and they're doing a lot of running, they'll tend to have a little bit of a thicker Achilles tendon than someone who's more sedentary. I think the same holds true for the IT band. When someone does a lot of running and the tendon's so exposed to load, you start to see a little bit of thickening at the tendon, which is probably a normal adaptation there.
Hmm. Yeah, it's kind of interesting because we always learned that the IT band was kind of tight, and that was the problem. What's interesting is that we almost want it tight, right? And these studies on the Achilles tendon and also with the IT band, when folks kind of start getting out of pain, the tendon kind of gets stiffer and stiffer, right? So it's like, well, if stiffness was the problem, how can we get stiffer when it's getting better? So that's pretty interesting. That's like a paradigm shift. The other thing I thought was really interesting, and we'll talk about this with Pez and Serene as well, is that the IT band is also that varus stabilizer. And with a few other structures on the lateral knee is really important for resisting varus force. Also really important for folks to have, let's say, an LCL injury or some other issue. I have that going on right now. So it's kind of in my mind, it's like, what other structures do I need to try to strengthen to stabilize the outside of my knee? But just kind of interesting, cool structure, probably poorly understood. Seems like we're getting more information now. So all good stuff.
All right. So, what functional activities load the IT band the most? So, you could think it's tension to a high degree when it's contracting eccentrically. So, when you have a combination of hip extension and knee flexion, so tasks like running downhill puts a lot of load through the IT band. Descending stairs, especially if you're keeping kind of an upright torso. Walking downhill, similarly as running, you're going to get some load through the IT band. And then in terms of the gym, like a rare foot elevated split squat, when your leg that's behind you up on the rear foot elevated machine or a bench, as you come down into hip flexion, that back leg is actually in hip extension and the knees flexing. That puts a lot of load through the IT band. Another common test that we think about is like the Thomas test. When you're looking at someone in that position, you're tensioning their IT band, and you could be looking at pain provocation with that, but you are putting a little bit of load through the IT band in that position as well. And then, as we had mentioned, it also resists varus loads. So when does that happen? Um, if you have like a narrow step width during running, if you're running on a slanted surface, so you could even think about if you're running around a track, that outside leg might be resisting various loads, getting some load through the IT band. Um, so those are just a few activities you can think about, so you know when to expect the IT band to have high loads and when that might contribute to the person you're seeing.
Mhm. And I do think that I'm probably getting ahead of both of us. But when you're trying to rehab something, you need to know when it's being stressed. And obviously, for so many other conditions, we're probably going to have to offload this a little bit. And we're probably going to have to ramp up the stress on this over the course of time and strengthen all those surrounding muscles and strengthen those specific positions. So, if you know what the heck the IT band does and when it's stressed, then you can start to think about how do we unload this and how do we start to load it and progressively ramp up. I don't know if that's actually true. Are we going to get into that coming up
Oh, we
next?
are. I think that's the key to PT right
Mm,
there. So
all right.
that's what we will talk about that.
Excited.
So the first key here is, I think, understanding what not to do. Um, we're in the business of trying to stop the spread of misinformation,
Whoa.
right?
It's like a
So
disease, man.
yeah, yep. So one thing we had talked about when we first started was that um, commonly going through school, learning earlier in my career, seeming like the IT band was a problem of it was a friction-based injury. So often the patient was told that they're having IT band pain because their distal IT band is snapping back and forth over the femoral condyle. Um, and the idea was that from 0 to 30 degrees of knee flexion, translation of that IT band is what was causing them pain. It was going back and forth and snapping, and that became painful. But as they've studied the anatomy a little bit more, it's believed now that the distal IT band is actually the posterior fibers of it are actually tethered to the femoral condyle, which wouldn't allow for a friction-based mechanism. So when the fibers are actually attaching there, it's not going to have the ability to snap back and forth over it. Um, there might be some nuance there, and you could think that all of our anatomies might be a little bit different. And I will say anecdotally that I've seen people with IT band pain who do get a little bit of a snapping is what you feel like you can feel it. Um, and whether that's that temporarily, just how other tendons get inflamed and irritated early on, maybe there's a little thickening of the tendon and that's causing something to change. But we still don't think that's the main contributor to someone's pain. Um, it's now believed that it's more of a compression based issue. So when the knee is flexed from neutral, from 0 degrees to 30 and beyond, those posterior fibers of the IT band, there's a fat pad that's distal on that lateral knee. And we think that it's compressing the fat pad. And fat pads are highly innervated, so they can really be sources of pain for folks. So it seems like it's more of that compression based injury rather than a friction based injury. And that will have implications for treatment as well.
Yeah, pretty interesting, right? And I was reading all about that too. And I know Rich Willie is always he's kind of adamant about pushing the fact that it's more compression based. But the thing is funny is that we've talked about this a little bit. It's like I've very clearly seen patients where they have something that really looks like it's snapping underneath the IT band, right around 30 degrees of knee flexion. Right, there's some tissue that's sliding. As soon as you start to extend the knee, pop, it goes right underneath of it, goes the other side, and then you flex the knee and pop, goes right to the other side. So I don't know. I think it's partly like sometimes ego. It's like,
Hmm.
oh, is this, it was snapping. No, it's compression based. No, it's snapping. People go back and forth. At the end of the day, it's like, all right, well, something on the side of my knee is mad. It's making it mad. And we probably need to make sure that we get that tissue to tolerate the snapping or compression, right? Either one. So I just find it funny. And it's, we're making this case for compression, although very clearly we've seen some patients that it looks like it really is snapping, but who knows, right?
I'll just say quickly on that, like one reason why I think it's important to try to differentiate that. And you're totally right about like, you know, there's definitely a camp of people who want to pretend they know everything and that everyone else is dumb for thinking this old thing we used to think. And certainly that's not what we're trying to do. But I've definitely had people come in who are afraid to like cycle, like riding a stationary bike or run because they think that they've had this IT band pain in the past, and they ask like, isn't that's going to continue to snap back and forth, and I'm going to get my IT band pain again. So, I think for patient education, it could be helpful, but obviously we got to keep an open mind because this stuff's changing, and maybe we'll learn in a few years that there's some combination of maybe snapping in some people and compression in others. But that's what the best our best guess right now is. It seems to be mostly compression. Um,
Yeah.
yeah.
I was gonna
For
say
the
it's a good point. Yeah.
Yeah. For the second point here, under telling patients or understanding what not to do, is telling your patient that their IT band is caused by hip weakness. So I think with the IT band here, it's kind of similar to patellofemoral pain. A lot of times people look at like the Q angle and think that either statically or with movement that their hips are weak and that's why they're having some of this pain. Um, and we do see hip weakness in people with IT band pain, but that seems to be a result of having IT band pain, not the cause of the IT band pain. So whether that's like a central nervous system reducing motor output potentially, or they're sedentary for a period of time, because you'll see these folks usually, months after they've had their initial symptom. Maybe their lack of activity has caused them to get a little bit weaker. But we do think that these folks have hip weakness, but it's not the cause. So, telling someone we have to get your glutes and hips a lot stronger because your mechanics cause this pain. We can't necessarily say that, and we don't want people to think that. And then we do see higher hip adduction and femoral internal rotation moments in runners with IT band syndrome. Um, but again, is this a weakness or is this a gait issue with running? And I think that gives us a lens into treatment as well, because we'll talk about gait retraining. And we also know that when you undergo a strengthening program, actually, Dan, you and I were talking about this in the clinic this week, is that for runners who start to do more strengthening, it doesn't seem to have an impact on their running gait and their biomechanics with running. So, it's not like if you have more femoral internal rotation and hip adduction during running, and then you strengthen your hip external rotators and abductors, that it's going to better align you with running. Maybe on the very extreme, super extreme, maybe that would happen, but we don't tend to see that. Folks undergo a strengthening program and their running mechanics are relatively the same. So, we could make the case to strengthen the hips. We know that they're a little weak now. Maybe it will make them more load tolerant, so then they can better handle the stresses of running, but not because it's going to change their running mechanics. And we'll talk about treatment a little bit later, but that's just a key to understand, is don't tell your patients that your hip weakness caused this.
Mhm. The other thing that I talk to students a lot, 'cause I feel like it's a bit of a misconception, but let's say you have a weak quad and you have knee pain. And you see this a lot with like post-op ACL reconstruction. When you ask them to jump, hop, land, they don't use a knee strategy. They don't land through the knee. They don't flex the knee more when they have weakness or they have pain, right? For whatever reason, we believe at the hip, if you move through the hip, oh, that's weak. That doesn't make any sense to me,
Mm,
at least, right? I mean, maybe if you hip drop so considerably that you're getting kind of that capsular restraint to motion and you're bottoming out the end range of hip like adduction, getting like such severe hip drop that you're actually getting the passive structures taking up some of that forces, maybe. But if you're running and you have substantial hip drop, it's probably because you have a strong, robust hip that's able to handle those forces. You know what I mean? So when folks say like, "Oh, the reason why you have hip adduction or hip drop is because you have hip weakness," I'm like, that doesn't make any sense at all. Like, why would your body decide to use this as its primary engine to propel yourself forward running if it's weak? It just doesn't make sense to me. So I think that, the research is not supporting what this whole idea that hip weakness is leading to people having ITB pain. And the secondary thought is like, if you're moving through your hip, you probably got a strong hip, right? If you're not moving through the knee, maybe you're moving more through the hip because it's a stronger, more stable joint. Sometimes getting the knee stronger will help you move less from the hip potentially, as long as we kind of gait retrain, so on and so forth. So I'm getting on a soapbox, but I just think that's really important. And oftentimes, a lot of students we talk with, it's kind of a paradigm shift, right? It's kind of an interesting thought experiment. So,
yeah, that is really interesting. I never really thought about it like that. And maybe on like the most extreme form of quad weakness, you have like your quad buckling, but
hmm
that's like a early post-op issue. That's not like people, or unless you have like a neurological weakness, people don't have quad buckling most of the time, right? So
hmm
I never thought of it like that, but it's a good point.
yeah, and those folks, they move way less through their knee. They stiffen up the knee. They don't allow the knee to flex, right? It's
Right.
not like, oh man, you got a weak quad, you just hit the floor every single repetition. That doesn't happen.
Yeah. Yeah,
So,
it makes me wonder a little bit too about maybe static foot posture versus the amount of pronation with running, you know,
hmm
similar thing. Yeah, just things to think about. That's
food for
interesting.
thought.
Yep. The third thing here, just understanding what not to do is focusing. And I don't see this as often anymore, but I do remember being in PT school and like working as a rehab aide, seeing this and hearing this pretty frequently. But focusing solely on foam rolling and stretching, what would be the reason for doing that? So if we assume that your IT band is tight and that's what's causing this issue, Part of the issue there is there's no reliable way to assess IT band length. Like the Ober's test has been kind of shown to not assess length the way we thought it did. It's not the best way to look at the IT band length. And then the other thing is, thinking if it is tight, that we have a solution for that tightness. We really don't. There's no good way to stretch or lengthen the IT band. Another thing to just consider is that if this is a compression-based injury, why would we want to further compress the distal IT band, right? So if, what I generally think is, foam rolling kind of, if it feels good, if you feel like it makes you feel better. Personally, I think using a foam roller, I feel like it helps me a little. I feel good. It makes, it's like any massage technique. But just understand that it's for a good feeling. It's not changing the tissue necessarily. And you did mention this a little earlier, Dan, and I think we see this with tendons quite a bit. We may want it to be stiff. So if we're thinking we want to roll it out because it's too tight, we probably want IT band stiffness for performance, especially with running. So there was a 6-week study that looked at changes in IT band stiffness, and those with IT band pain and those that were healthy controls. And there was, no difference between groups pre-intervention. So, both groups demonstrated about the same amount of stiffness in their IT band. But after the IT band pain group, they had an increase in stiffness and they had a decrease in pain. So as they went through their rehab program, their IT band got stiffer and their pain improved. So whether that's a, 1-to-1 ratio or, exactly how that works, but as pain came down, stiffness got better. So perhaps they were going to their, previous level of stiffness, or they just found it through a rehab program that stiffness was advantageous. So just something else to consider.
I feel like I stole your thunder, man. I didn't realize you were going to go so in depth on that. And I just
That's all
like
right,
stole
man.
it.
You
You
set
know what I
me
mean?
up.
Yeah.
Yep.
Sorry. Yeah, that's really interesting, right? So stiff IT band, potentially better. I mean, obviously we don't know for certain here, but it is interesting to see that trend of as you improve, pain goes down, stiffness goes up, right? And then a couple other thoughts too. Like I don't primarily give my patients a lot of IT band foam rolling, right? Usually. What I will say is that I feel like foam rolling as well as other manual therapies can be very helpful for reducing patients' pain. So if a patient's already doing it and they're finding good effect, I don't stop them. I may actually give it to them because it may make them feel a little bit better. And that's my same rationale for manual therapies because largely we're probably having more neurophysiologic effects anyway, right? And if I want to try to reduce a little bit of pain via soft tissue work, right? Working, let's say, IT bands, working a little bit more through the TFL, glute medius, I'll do it, right? My other thought too is like, yeah, I'm not going to wail on the side of the knee with the foam roller. But my next thought is like, well, when you have other tendon problems, right? And one of my thoughts too is like, I don't know, let's say bicipital tendinopathy or lateral hip pain. We smash the crap out of it with like extracorporeal shockwave therapy. And that seems to help. I'm not saying that you need to foam roll your IT band now. Sorry, my mic dropped a little bit here. Hope my audio was okay. But I mean, we are compressing the IT band by foam rolling it. And maybe that does have a beneficial effect. That's me being a contrarian because what we're trying to do is get the IT band to handle compressive loads. If we throw a compressive load on it, maybe that helps. But the other part is like maybe it comes down to dosage and the specificity of the intervention is probably not great. So if I'm going to do weight bearing exercise, that's probably how we want to train the tissues as opposed to hitting it with a foam roller. But I don't really know. I just think it's interesting, again, a little thought experiment there. But yeah, like rolling over and over again with a foam roller, if you're dealing with something that's already being compressed too much, doesn't seem like the smartest thing of all time.
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for 1 week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
All right. And now key number 2, just shifting. So understanding what to do with your patient. And I think the first thing is just take a solid inventory and kind of make sure that you're understanding where this person's coming from. And these were some of the things that Dan had talked about in our previous episode on just what to know about IT band pain. But you want to understand the mechanism of injury. So you might have to dive a little deeper in the subjective exam, figure out, was there a change in, if it is a runner, is there a change in the volume of running? So how many miles they were doing, the intensity, or the training surface. So like a lot of other tendon type problems, there's usually a change of some sort that we could quantify and figure out, this is most likely a training error. So how can we prevent this from happening again in the future? And how do we ease back in at a slower pace so they're not getting agitated? The other thing we want to consider is just how irritated is it, right? So we could use something like the pain monitoring model, get some idea of what their pain has been like. If someone's coming in and they're able to run and they're telling you, well, like halfway into my run, it's probably a 2 or 3 out of 10. When I finish running, it's usually okay. The next day, it's okay. It's just a little irritating while I'm running. We probably don't need to stop that person from training versus someone who comes in and they say that, it used to hurt only when I was running, but now, when I'm going downstairs, it's really bothering me. That's important to know so we can think about how we're going to start our treatment plan. That person's probably not going to be able to run right away. So figuring that out is pretty important. And then just, the whole time we're asking these questions, we're starting to think of how we're going to structure our treatment program and figure out, do we need to modify or do we need to remove for the time being? Can we maintain what you're already doing, or can we start to make progressions? So, you're always thinking of those things as you're taking your inventory and you're doing your exam so you can get this person on the right track.
Very solid, Kevin. I don't have anything to add.
Awesome. So, depending on where that person is, the second thing I would try to think about is, can we modify before we remove? So if the person is dealing with like an acceptable amount of pain with running, which what I would say is, kind of what I was just saying. If it's a stable pain that they're getting with running and it's really not bleeding into their other daily activities, it's not causing them to change their running mechanics because of the pain they're having, they're probably safe to run. It's not like this is going to turn into a bone stress injury or they're not going to tear their IT band. So, they don't have to be fearful about running with some pain. But, I think once your mechanics start changing because of pain, we should probably modify. So in terms of running, the first thing we want to try is gait retraining. So before we change the running surface, we change the course that they're running on, we could consider just a little bit of gait retraining. And I'll talk about this more in the next slide, but that can be really impactful. So just remember that we see more femoral internal rotation and hip adduction in runners with IT band syndrome. And clinically, this will present with a more narrow step width. So if you take someone through a running gait analysis, you'll see a narrow step width. Sometimes they actually are crossing over. So like, it kind of looks a little funky, but their right leg will swing through and it might cross over their center of mass to the left side. And then the left leg will come forward and do the same thing. And then just remember that strengthening for this person, although it's going to help increase load tolerance to the tissues, it's probably not going to change their running mechanics. So this is where gait retraining will come in. We can also use mirror feedback. A painted line on like the road or a track, you can have someone use as a visual external cue. And then cadence, which is step rate. So go to the next slide for a sec, Dan, just so I hit on that. So just on running cadence, this has been shown to be super impactful for people with all different types of knee pain. And a 5% increase in running cadence reduces peak hip adduction by 3 to 4 degrees. So, if we're thinking that crossover gait where they're getting more hip adduction, that's going to cause more compression at the distal IT band. So if we can get rid of that a little bit or help them widen their step width by 3 to 4 degrees, that could make a decent difference for the person. It will reduce IT band strain. That 5 to 10% increase in cadence has also been shown to reduce eccentric forces at the knee from about 20 to 33%. So again, taking some load off the knee, it's going to shift load somewhere else. But if this person can tolerate that, it could be super helpful. And then peak tibial femoral contact forces are reduced by about 8%. And it increases step width. So, if I were taking someone like through a running gait analysis, there's an app I like to use called Tap That Tempo. It's free. It's, super easy to use. Essentially, you're watching someone run, and every time their foot hits the ground, you're just tapping your phone, and it comes up with the number of what their cadence is. So, perhaps you have someone presenting with distal IT band pain. They have a crossover gait pattern, and their cadence is somewhere around 160 steps per minute, right? So if we can go ahead and increase that person's step rate by, 10 to 50 or 5 to 10%, say we bump that up to like 175 steps per minute, they can go ahead and sync their running with a metronome. There are tons of free metronome apps. They can go ahead and like Spotify or Apple Music have playlists that are set to a certain beat per minute. So you're actually listening to real music. I don't have a musical bone in my body, so I can't feel that, but I know a metronome has worked for me in the past. And so what you'd want to see is that when you're looking at their running after you implement that strategy, do they have a little bit more wider step width? And, if we can get someone from a 3 or 4 out of 10 pain to a 1 or 0 just by increasing their cadence, that could be a huge impact that is positive for them. And we don't have to cut out their running. So that's definitely the first thing I would look at in terms of treatment for these folks.
Mm-hmm. Did you need the other slide, Kevin? Are you good here?
No, I'm good. Yep.
All right, cool. What I will say is I think the cadence piece is a game changer. And I think most folks that are probably watching the Fitness Pain Free Show are probably smarter than the average bear. But I can't tell you how many times a patient has come in and seen another physical therapist and they had knee pain and they didn't try to measure or alter their cadence whatsoever, right? And one of the biggest things that we're trying to promote for runners, but everyone really, is that how can we maintain what the person loves to do as much as possible? Because you get an extremely strong kind of psychological benefit, right? This is kind of a Chris Johnson thing, but people have an identity crisis when they have an injury, right? They lose the thing they love the most. So I think from a physical therapy standpoint, if we can keep them moving, they're going to reduce capacity less, which we see as a problem as well. I see some folks have IT band pain. They stop running and they essentially were getting pain around the 4-mile mark, and then they rest and they come back and they actually get pain more at the 3-mile mark. And they rest and they come back, and now the 2-mile marks, they actually kind of get worse and worse over the course of time. If we can maintain their fitness, we keep that capacity higher, right, and allow them to do the thing they love, and potentially just altering the dosage of running might be the actual rehab itself. You know what I mean? So I just think that's super powerful. The second thing you kind of mentioned was, yeah, you try these things and you see if it reduces their pain. One of the tricky things I've found recently, I'm just thinking about a specific patient, is that this patient didn't have pain until mile 4, right? And they've actually had this pain for a few months. And when they came to me, I was like, all right, well, let's try some running and let's see if we can maybe tolerate some flatter surfaces and see if that helps out. That was one of the first interventions we made. And I was gambling a little bit because I knew this person was extremely frustrated and they wanted to run. And I wanted to give them the ability to run, right? But they went for a run and they got painful to our earlier point sooner than usual, right? Which that stinks. So now he's in the middle of the woods and he has to start walking, right? To try to get home. And I lost some trust with him. So I think that's problematic because essentially now folks get in this psychological whirlwind again of like, oh crap, it still hurts worse now. This guy has no idea what he's talking about, right? So you have to be a little bit cautious with this. So obviously you want to try to do some gait retraining, get people to run a little bit, but you do have a whole host of issues that come along with giving the advice and then folks maybe not following it, or folks following that and getting hurt again and then not believing you. And I will say this gentleman has not been back since. So hopefully I didn't lose him completely, but I feel like I may have just because he lost so much trust from me doing this, unfortunately. So that is a thing.
Yeah. Yeah, I think that's important for people to hear. They just think probably sometimes listening to you talk that every single case isn't a home run, right? So it is important to share that story, I think, for people listening, because you can try all the right things and sometimes we're trying our best with what the research says, but there will never be an IT band pain study where 100% of folks have a positive outcome with the intervention. So, sometimes there's so much else going on in someone's life. It's hard to, and maybe there is no one solution that would get that person better on that next run. But yeah, just something important for listeners to keep in mind is, we definitely make mistakes and we're always trying to improve.
And that rapport and trust is so huge. I think a lot of times, physical therapists may get into hot water because they're maybe not practicing something that's mega evidence based, right? It's just that sometimes if you jump the gun and give them what you feel is maybe best for them based on the evidence and they have a setback, which we know is part of it for sure, they don't have to come back. So what we're trying to do, and I think that physical therapists don't get enough credit for, is keep them around, build them trust, get some wins so they actually stick around. But at least here in the States, people are free to go wherever the heck they want to go. So if they don't like your treatment, they just leave. And I could have the best treatment, but if you make them painful and they don't believe you, they're free to go somewhere else. And they may end up spinning their wheels and not getting better, right? Maybe if they stuck with me, they do better. I'd like to think that, but that's not always the case. So yeah, more food for thought. I hope you guys are, hungry for all this food coming your way.
Yeah.
Brain.
Yep.
Yeah.
All right. So the key number 3 here is coming up with a phased treatment approach. So we kind of referenced this a little bit earlier. I think a lot of pain conditions that we treat fall into this approach. But the first phase there is just calm it down. And, if the person is functioning at a high enough level where they're running, 4 to 5 miles without a ton of pain, we might be able to skip this phase. We might not have to totally calm it down. But, for those people who can barely run, they're having pain with, day-to-day type things aside from just running, we should probably enter this phase. So we can educate the patient on a pain monitoring model, figure out how much we need to modify. And if we're in this phase, then we still want to load the person. Like Dan was just saying, these athletes, we don't want them to have like an identity crisis where they totally can't train at all. There's totally things we could figure out that can allow them to keep training. So if this is a problem at the knee joint, why don't we just load the hips a lot? Why don't we do some hinging movements? Why don't we do some loaded carries, some hip accessories, train the calf, all the surrounding muscles, some core. There's probably some type of cross training that they can do to keep their cardio high. So, there's things they can do in this phase. And I think you could work with the patient and see what they really enjoy doing. If they're like, hey, I love doing the elliptical. You could probably figure out a way to make that work based on how they're feeling. So just be creative and work with the patient, but we'll temporarily reduce loads at the knee joint and try to load up some of the other joints, let it calm down before we start to progress to the next phase.
Yeah. I just will say, I think this is super duper important. And sometimes it's the hardest things we do as physical therapists, because I think sometimes if you're like the running expert and someone comes to see you, right, as a runner, they're kind of looking to you to figure out a way they can kind of continue doing the things they love, right? And I think being really good at this is really helpful for patients because they obviously want to run really bad. If we can create something that's as close as possible to their normal running program and allow them to rehab at the same time, I just think that's a major win. So, yeah, follow some of these strategies. You have to wiggle around. Sometimes you hurt patients, like I had said previously, but I do feel like this is something that can be super powerful. So,
All right, and then phase two, we start to build it back up. So, I think you can start to enter this phase when, if you do go through phase one's going well. And in my mind, they should be mostly pain free with activities of daily living. So maybe that pain they had going down the stairs is getting better. And we're kind of in that intermediate between that acute phase and, fully returning to run. So in this phase, we're going to focus more on closed chain exercises, specifically at the knee joint. So maybe initially we focused on exercises with the hip and knee both in a flex position before progressing to an extended hip with knee flexed. So for an example, that might look like a split squat where initially maybe you could keep their trunk forward a little bit. They have a small step width, so they're not in a ton of hip extension in the back leg. And then progressing that to like a rear foot elevated split squat where we're increasing loads through the IT band. We'll probably begin by loading the sagittal plane before loading the frontal plane, where we'll see a little bit more varus stresses on the knee. And then I think often overlooked part of this phase is focusing on plyometrics. So like I had said earlier, we could think of the IT band functioning like a tendon. So there's a lot of energy storage and release going on. And we utilize that energy storage and release in plyometrics. So again, I like to start in the sagittal plane with a shorter range of motion. So perhaps something just like, pogo jumps, you could go in place. I like to do them moving. So you could go forwards, backwards, and then adding in the frontal plane. So maybe we're going sideways with those, jumping side to side, progressing to single leg like skater jumps. So then you're getting some of that varus stress on the knee. And then we go from a smaller range of motion to a larger range of motion. So something like a split stance leap, where you're kind of doing like a pogo in a split stance and you're just trying to be really reactive there. You're getting a lot of loading through the calf complex and the Achilles tendon. And then to like a more deep tier split stance leap. So like a jumping lunges where you're really sinking into the movement, trying to be quick out of the hole there. And you're getting a lot more load through the IT band. So, you start easier in this phase and then progress based on the patient tolerance.
mm-hmm. All right, quick question for you, Kevin. If your patient's doing pretty dang good from the get-go, like my patient that only has pain at like mile 4,
Mm-hmm.
you can tolerate jumping from the start of rehab. Do you give them pogo jumps at the start of rehab?
Yeah. Yeah. I think there's a few reasons you could do that. I think, if we're looking at a runner like your patient who, presumably is trying to get healthy, but I think like most runners, maybe trying to improve their performance, especially as we get into like the master's level age. Um, we know we have reduced strength in the calf complex and the Achilles tendon. So maybe this is a type of jumping that they've never done before that can be really helpful for loading the calf and getting them a little more elastic, and might have good carryover to their running performance. If it's someone who we're trying to load the IT band and we don't necessarily have to take out a lot of IT band stress, I think we could maybe progress past that. But I think it's something that has a place in runners programs from a performance standpoint, just to keep the calf used to working in a very quick stretch shortening cycle.
Mm-hmm. Good stuff. The other thing I will say, and this is kind of anecdotal, but I find myself doing this a lot with most pain problems. And a similar pain problem to IT band, which I see a lot, is gluteal tendinopathy, so glute medius tendinopathy. So one of the little quick things you can try, so if you're doing, let's say, a split squat, and that's painful, you don't have to automatically say like, okay, this is, too much. Let's try another exercise. You could probably just try widening their stance, right? And oftentimes I find this is really helpful for those folks. The other thing you can try to alter is hip drop. So if you're doing, let's say, a single-legged squat and that's too painful, you can obviously maybe modify the depth, modify the loads, the speeds, but you can also try to correct that hip drop and see if that changes pain. And again, it's not like I'm going to tell them to run for the rest of their life with an absolutely level pelvis, right? Necessarily. For the time being, I think that can be a nice modification, allows them to train without getting too painful. So do keep in mind, you can kind of modify the exercises based on how they respond, try to clean up their technique, see if that changes things a bit. And at the end of the day, you're kind of giving that person the most that they're able to tolerate without aggravating them too much, right?
Mm-hmm.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
All right, then that third phase here, if you're going through these phases, is returning to running. So I think after a few weeks of success with loading strength training movements where we're loading the IT band, they're tolerating plyometric loads to the IT band as well, we can introduce a return to running program. So with the IT band, I had said that when you're running downhill, you're getting a lot of load through the IT band because you're in that combination of hip extension and knee flexion. Starting by running uphill can be really helpful for these folks because there's a lot less load going through the IT band. So perhaps earlier in this phase, like phase 2, we're doing a walking program to kind of bridge that gap as well. So maybe they're doing an uphill walking program to start, and then we're progressing to, an uphill jog. So maybe like a 3 to 5% grade on the treadmill, which can be pretty exhausting from a just, exercise standpoint. Like you're loading your calf complex a lot, get your heart rate pumping, but it is lighter load on the IT band. So maybe we're doing intervals of, that uphill jogging, that 3 to 5% grade with walking. And then we're progressing to running on flat ground. And then, it depends on the person's goal. So I do think like a trail runner is going to be more challenged to get back to trail running than a track runner would, perhaps, because in the trails, the trails are going to be undulating uphill and downhill. They're going to be turning quite a bit. and that turning, kind of like pivoting off and turning in the woods, will increase the varus load through the knee. So that could be more challenging to get back to. So kind of just think, what's the end goal? Always work with the person. So they're trying to get back to trail running. Perhaps you start with that uphill jogging program to flat ground, and then maybe like a rolling hill outside on flat ground, and then you get back into the trails. So you could consider that. Just think about, we talked about what things stress the IT band, and then how you're going to bridge that gap to their end goal. And then, so just zooming out very generally, we could start with a walk to run ratio of, maybe something like 2 on, 2 off, or it could be kind of arbitrary depending on your person's goal, you can get more specific. And when I'm going through that, I think in a perfect world, if we have plenty of time, they don't have an immediate goal on the horizon, I like to complete each of those return to running phases twice before progressing to the next one. So maybe we do 2 on, 2 off. We complete that twice just to make sure it went well both times, and then go to the next one. Maybe that's 3 minutes on, 1 minute off. Complete that twice, and then maybe you go 5 minutes of straight jogging with a minute walk. And then, that way, I like that because I've seen people where it feels good once, they go to the next phase and they're kind of bummed out. So you kind of make sure it's not a fluke, or they have a little bit of time to adjust to that interval that you just gave them.
Yeah. We're taking a lot of notes here, Kevin. I got some things to ask. One thing I think is really valid that you just remind me of is that I've had several patients where they kind of start a bit of it might not even be a return to run program, but even just a strength training program where things seem to go really well. And then a couple weeks into it, things get flared up again. I remember when Tim Gabbett came to Champion to give his talk about the acute chronic workload ratio. And one of the things he was saying is that a lot of these injuries aren't showing up until a few weeks after that spike. So I think the thing to keep in mind is that if you're getting your patient to start running, you're spiking that training volume, and they may not become painful for a few weeks after that, right? And that's unfortunate because you're kind of always guessing. You're starting with a little bit and ramping up as much as possible, but be prepared for that and just keep that in mind. I just educate patients more and more. To my earlier point about that prior patient who said, what we're doing right now is a little risky, but I'm doing it because I know you want to run and I want to keep the capacity of this area high. So probably just educating your patients. The other thing I want to ask you, Kevin, is that, like, if you do have a patient that hurts maybe at mile 4 or 5, but they're pretty non-irritable, pretty low level of irritability otherwise, would you start a return to run program from the get-go?
No, yeah, I would allow them to go up to that point. So say it's mile 4 and they're pretty much 0 to 1 out of 10 up until that point. I would try to keep that in, and if there were low hanging fruits with the changing running mechanics, maybe we work on that a little bit. But I would probably try to give them some exercises in the gym that will increase load capacity to the IT band, and then see if we can, maybe for a period of a few weeks, we know they can tolerate 4 miles. Try to get consistent with that, and consistent with loads in the gym that will increase load capacity to the IT band. And then, say they're running 4 miles 3 times a week. I would probably try to, if their goal was to increase mileage, again, I guess it would depend on what they were trying to get back to. But say they wanted to do 2 days of 6 miles and 1 day of like 8 to 10 miles, but currently they can only do 3 days at 4 miles. I would try to keep 2 of those days at 4 miles and add a mile or 2 to their long run each week, and kind of build that up first, because I think from a cardiovascular standpoint and a running performance standpoint, having a solid long run in the training schedule will benefit them a lot. And then once they're kind of sitting there tolerating that, we can build up those other 2 days slowly. That's kind of how I would think about that, is like, what's their end training goal? And then let's modify 1 day at a time. And if they can already tolerate a certain amount of running, I don't think they have to go through a slower progression.
That's kind of what we did with this runner when he came back. Was we're like, okay, well, it seems like it is, a distance thing. And what I did was we figured out how many miles he wanted to run per week. I tapped a little bit off of that just to be reasonable. We tried to split up his running more days throughout the course of the week, which is a huge pain in the butt because he's a busy person, doesn't always have time to run, but he's also doing a lot of biking and other cross training. So that was my advice to him at that point. So it's good to hear at least. One thing I will say before we move on is that like I said, I had a recent knee injury, and uphill running was a game changer for me. It's very interesting. Oh, like a 5% grade. I actually started higher than that initially, but I couldn't run whatsoever. I just didn't tolerate any of the impact of it. But if I went uphill, it felt great. What I will say is that uphill running, particularly on the treadmill, what I was doing, more strain on the calf, just strained my calf like 2 days ago. So it's funny. It's that robbing Peter to pay Paul. And I'm always careful with patients, especially if they have a history of Achilles issues, something like that. It's like, hey, let's try some uphill walking, or excuse me, some uphill running, see how you do. Not very much, like 3 to 5%, right? And just be careful not to go crazy because we can flare up other pain problems, right? So if you have a history of Achilles issues, calf strain, so on and so forth. And I started to feel it in my calf as I started to do some uphill running. So it's always challenging. Just roll with the punches, right? And that's why I tell myself when I hurt myself. I was just sprinting on the treadmill the other day, and I think Kevin saw me clutch my calf as I was going, felt like an idiot. But it's all part of it, right? Just some things to think about.
All right. And then just a little bit about other treatments. So there are some other things we can look at. In this study, iliotibial band syndrome, current evidence. They've looked at orthotics, but I think more research is needed. Potentially, it could be successful combined with exercise therapy. Usually for this, if you're thinking orthotics might be helpful, sometimes what I'll do is I'll tape someone's foot in the clinic, see if they have any type of positive response. And if they do, and the taping I did was to lift up their arch or something like that. And they were like, hey, that made my IT band feel a lot better. All right, go get an over the counter arch support. Maybe that could be helpful for you. Corticosteroids, we need more long-term research, but potentially when exercise and modification fails and you're just not getting the results you want, this is something you could potentially try. For shockwave therapy, I think more and more research is looking at this for different types of tendon problems. It does seem like it could provide some benefit. It has some comparable outcomes to other treatments. We're a little spoiled where we work. We have a ton of time with patients and we can use this machine whenever. So, if you are in that situation, why not do it? Kind of throw the kitchen sink at it. Anecdotally, I have a tendon issue right now, and I find this super helpful. I think we can both say we've had patients with tendon issues and we do some shockwave and they're like, holy crap, that feels great. So just something to keep in mind, maybe be on the lookout for the research and see, if there's more and more positive findings. There is a surgery they could do, but rarely are people getting this. And what they do is they release the distal IT band, and there's excellent to good patient satisfaction in returning to activity. And one study showed 81 to 100% return to sport rates, which is pretty good. But this might be like an all else fails and you're desperate type situation, but it is an option for folks.
Mm-hmm. It is kind of funny. I think Kevin and I were talking the other day about how good we are at helping folks with certain pain problems. And we'll talk about Osgood Schlatters in a bit. And then we've also talked about patellar tendinopathy. And can we have success? Yes, but it's not great. Even with patellofemoral pain, we've got research to show that after treatment years later, folks are still dealing with these lingering pain problems. And I think we're really quick to kind of poo-poo a lot of these surgical interventions. And especially because for IT band, this is an odd surgery, right? Folks aren't often getting that. And the research isn't super robust, which is always a little scary, right? Because if there's not a ton of research showing this is helpful, like anytime people are cutting things, you're losing parts of your body, can't go back after that, right? So it's a little scary. But what I will say is that that's pretty dang good. 81 to 100% return to sport rate. So yeah, I would say that as physical therapists, of course, we're trying to push exercise and then more conservative treatments. But in case of some of these surgeries and like debridement for the patellar tendon being one of these as well, folks will tend to do pretty good with that surgery. And it seems like this surgery is decent as well. So if you have that kind of really recalcitrant issue, you've tried injections, you've tried shock waves, you've tried everything, and it's not getting better. I think if you tell a patient not to do surgery, you're potentially limiting their long-term outcome. So these are options. right? It's just good to have, good surgeons on board that can help out, and additional docs that specialize in things like PRP and Shockwave that you can refer to if your patient is not making progress. So first thing you do, definitely not. But also, I think that physical therapists should be open-minded to some of these treatments when conservative therapies aren't working. All right, so Kevin just melted your entire brain with all the research on IT band pain treatments. If it's not too melted, what I recommend doing next is learning all about the most common form of knee pain called patellofemoral pain. Lo and behold, if you check right above Kevin's head, boom, there's a link that just appeared. I want you to click on that. And in that video, we'll go over what physical therapists need to know about patellofemoral pain, the most common form of knee pain in runners. See you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.